Dean's Leadership Summit, and we are seeing some really good results. It's very, very exciting. So while you are muting your phones or putting them on vibrate, I would like to point you all to the fact that this work really, really matters. We have a poster right here that shows the progress on blood pressure since we started working on this. So these numbers really got the Department of Managed Healthcare's attention back in 2007. And at that time, we reached out to the deans of UC Berkeley School of Public Health. Thank you, Dean Bertozzi, for carrying on this great tradition. And also UCLA School of Public Health. And we said, we don't know what to do about this, but we do know that this level of performance is risking lives unnecessarily, because this is something we know how to manage, and it's not, we don't have the indication that the patients are being protected by the available remedies that will save lives and prevent disability. So as you'll learn in great detail today from our amazing group of people that has come together today, it can make a difference to shine a light on the data. And we're very blessed to have that solid data to see how the performance is going. Now, that wouldn't happen without the Office of the Patient Advocate for the state of California, who's here with us today, that ensures that we have solid, audited data that shows the performance. And the great news is we're seeing amazing, amazing progress. So give yourselves a round of applause. And before I go on with the substance, let me just say for those of you, so in addition to muting your phones, please, if you need to use the facilities, take your breaks at your own leisure, out through this door to the right, or you can go out and around. It's right over here. Now, I would like to take a moment to talk about the fact that the Right Care Initiative is a team-based sport. And everybody in this room is on the team. Some have been on the team longer than others. And I want to just ask a few people to stand up. Liz Helms, you're moving in the wrong direction. Come on up here. Come on up here. Liz, Carla, Warren, I want you to be acknowledged. So please stand up wherever you are. And Carla, come out here. And Amanda, please stand. Amanda Liu. So the fact that you're all here today and you're going to have an amazing experience is largely because of the people that I've just asked to stand. We have been working together for at least 5 years, some of us more than 20 years. On improving clinical quality improvement. So I won't go on too very long, but I want to acknowledge a few other people. Some of them aren't in the room yet, which is sort of, it's interesting because one of the people who will be part of leading this day, actually there he is. Hi, Arnie. He usually likes us. Arnie, we have you up at the front with us. So this work would not be possible if we didn't have leaders over the years working together to come up with a data framework for accountability. And Dr. Milstein wrote me his last email at 4:10 this morning. I didn't have a chance to respond until about 6. But he has been a stalwart in creating the HEDIS data set, in creating the Leapfrog group, in creating the Pacific Business Group on Health. So many, many people have worked over a period of decades to make this day and this work possible. And I don't want to forget Bob Kaplan, although I don't think he's here yet. He said he would be with us today. So Bob Kaplan, perhaps I'll embarrass him later when he comes in, but he was a big part of how I was able to meet the whole San Diego group and get that going. So also, is Parag Agnihotri here? Okay, we'll talk about that in a little bit. Okay, so we'll talk about San Diego in a little bit. But Neil Kohatsu, I know that I saw you here. Are you at the Sacramento table? Oh, you're sitting, yeah, okay. So Neil Kohatsu is part of that backbone of this organization. We've been strategizing about the Right Care Initiative since, at least it started in 97, really. But he's the Chief Medical Officer for Medi-Cal. And in addition, Mary Firmison with the Health Services Advisory Group here. Mary, would you stand up, please? Everybody knows you. So part of what makes the Right Care Initiative work is that it is a very collaborative effort. Mary Firmison, Neil Kohatsu, and I started working on clinical quality improvement together in 1997. Betsy Thompson is a new member of the Right Care team, relatively new, only a few years involved. She's our Region 9 leader for Health and Human Services of the federal government. So thank you for taking the time to come over. These are all people who believed in the mission early on, and I have to say that our wonderful supporters here make it possible for us to do this work. This work cannot happen without resources. And this is a public-private partnership. A lot of people, I'm distressed to say, sometimes say negative things about the pharmaceutical industry. I have to say, as a grateful patient, I would not be standing here today if it weren't for the R&D that goes on with the pharmaceutical industry. So with that, let me just say, in addition to the Sierra Health Foundation, California Chronic Care Coalition, the Health Services Advisory Group, which kindly is offering you all your free CME today, Ralph's Grocery Company, Rebecca will be here shortly, her flight is delayed, Novo Nordisk, Genentech, Boehringer Ingelheim, AbbVie, Johnson & Johnson, and Sanofi have been supporting us for several years. Hi, Ray, come on in. Come on up to the San Diego table. Yeah. Okay, and is that Larry Friedman? You also belong at the San Diego table. Come on up here, front and center. So as you can see, a lot of us have known each other for a while. Larry, come on up. So Larry Friedman doesn't know it, but he had a lot to do with the progress we're going to learn about today at the Right Care Initiative. So we're going to see some mind-blowing slides from Brent Fulton, Professor Brent Fulton. Where are you? Please raise your hand. About the progress from San Diego. So these two latecomers, Ray and Larry Friedman, they were kind of why I chose San Diego as the pilot, because frankly, at that time, Kaiser San Diego and UC San Diego they were what we call negative outliers. Treating large numbers of patients concerning the Department of Managed Healthcare by looking at our data. So when we got an NIH Go grant, thanks to Bob Kaplan, who will be making a late entry here apparently today. Arnie, did he come over with you? Okay, well, so Bob Kaplan, who was at UCLA at the time, put in a grant to the NIH to take our Right Care Triangle here which is a synthesis of all of what we know about the best practices. He put in an NIH Go grant. It got us enough money to pilot in one community all of these interventions. And what we'll see in a few minutes is your work really mattered. And Ray got the Platinum Award, Kaiser, excuse me, but it was Ray who led that effort for Kaiser there. And UCSD also got their performance up to the 90th percentile on LDL and now on blood sugar control. And it was Tony DeMaria who will stand up for just a moment and take a bow. It was Tony DeMaria that when I showed him the data for San Diego, he slammed his fist on the table and he said, I'm going to do something about this. Mark my words. We will do something about this. And he has. He has been leading. First, we can tell that story in greater detail this afternoon, but I just want to say, awesome work together, everybody pulling together. Tony as great mentor to all of the medical groups in San Diego, providing that quiet support that is sometimes just gentle and in the background and sometimes in your face. It's, your patients are not older and sicker. And you can do it, and this is how. And if you don't know how to manage any particular patient, come to me, come see me, I'll help you. So with that, I just want to say this is absolutely a team sport. I love the people who've come together here today. I haven't acknowledged every single person in this room, and I'm sure there are many things that we will get to later today. But I want to just make a special thank you to two new team members, Mary Watanabe, who is the head of Public Policy and Plan Provider Relations for the Department of Managed Health Care, and Beth Batt from the Office of Patient Advocate, who has been a stalwart standing up for the patients for decades, for the Health and Human Services Agency, for various health advocacy groups, and now as the lead state official who's responsible for making sure that we have this critically important data that is accurate so that we know that in exchange for those premium dollars, patients are getting the appropriate care. So this is a support system for sharing best practices, and everybody in this room is part of making that real, and we're seeing data now that lives are being saved. So thank you all for being here.
Good morning, Mary Watanabe, Deputy Director for Health Policy and Stakeholder Relations with the Department of Managed Healthcare. I'm thrilled to be here with you and excited to hear about some of the innovative approaches that you have been working on to improve outcomes and the health of Californians. I want to just take a really brief moment to talk about DMHC. I have spent the last three days talking probably to some of your coworkers and peers at hospitals, FQHCs, health centers, clinics, working with community organizations and agents who are enrolling people into Medi-Cal and Covered California. One of the most startling things to me is that many people don't really know what the DMHC does. We are the regulator for 71 full-service plans and 50 specialized plans. But we have 25 million consumers in the plans that we regulate, and that, for some reason, is astounding to many people who are in healthcare. I think, but more surprising, what I want to talk briefly about is the role of our Help Center as the federal consumer assistance line in California, and what we are doing to help consumers. With the implementation of the Affordable Care Act, we've added over 4 million newly insured people to the healthcare system. I will tell you that many of them have never had insurance before. They have low literacy, they are non-English speakers, and the concept of health insurance and navigating the healthcare system is incredibly complicated. I have been working with those on the front line to make sure that they know about the resource that the DMHC can be. You have a card, a blue and green card that the California Medical Association has graciously printed. It was all I had with me today. But the cards have our help center phone number. And I just wanted to briefly highlight that we are actively assisting consumers with navigating the healthcare system. If you have never heard about our help center and you want more information, I will be here all day. Please connect with me. I am literally traveling the state to get the word out because we are the best kept secret in the state right now, and we shouldn't be. The other thing I want to make you aware of is, of course, you may know that if a health plan denies or delays treatment, an individual can file a grievance with the plan. If that grievance continues to be denied, they can file an independent medical review with the Department of Managed Health Care. We are currently overturning about 60% of those IMRs. About 23%, we're working with the plans. We call the plan saying, okay, we'll take care of it. About 40% are overturned through a clinical review. This is the moment in my presentation where people start taking out their cameras and taking pictures. That and our timely access standards. So I want to make sure you're aware of this. You may not be on the front lines dealing with consumers, but if you have staff within your organization that want to know more about this, please connect with me. The phone number's there. I have business cards as well, so come see me today. With that, I want to give Beth Batt an opportunity to talk about the great work of the Office of the Patient Advocate. We have had a phenomenal relationship with OPA for many years, and they're doing great work in terms of sharing quality data. So Elizabeth Abbott with the Office of the Patient Advocate. Thank you.
Good morning, everybody. I'm Beth Abbott. I am so pleased to be here, and I want you to know I brought cards for every single person here. So if you are the least bit inclined or wish to talk about anything that I mentioned here, I'm available and will be happy to speak with you. I'll be here all day, or almost all day. Some of you may know us as the organization that provides the data for the Right Care Initiative, for which we take a bow. Thank you very much. We're happy to do it, have done it for years, yada, yada. But I also want to tell you some changes that we have experienced over the last year. Some of it was kind of hard, but I wanted to tell you so you'll know what kind of business to transact with us and what's coming up. We are a state agency. I report to Diana Dooley, the Secretary of Health and Human Services. And I have worked, as Mary said, as a consumer advocate. I was CMS Regional Administrator. So I've been in this atmosphere for a while. Last year, the legislature decided that the Office of the Patient Advocate, or fondly known as OPA, should not try and focus their energy on following through on consumer complaints. Not that that's not important, that's very important, but there are a number of organizations that do that and do that well, and it does make a lot of sense to have another organization perform that same function. So they told us, in no uncertain terms, that our function was to be public reporting. So has anybody here, let me see a show of hands, has ever heard of the OPA before this morning? Wow, that is so deluxe. I love it. Okay, we are the people that put the data on our website, opa.ca.gov, that gives stars to health plans and medical groups. And so some of you may know us from that, and I think that's very important. We do a huge amount of work on that to make sure the data is right and accurate and displayed properly and all of that. We just put the new 2015-16 data, we do it every year, on our website October 8th. But here's the part that usually is the beginning of the movie. This is coming attractions. We have also been charged by the legislature to do a complaint data analysis. for the entire state of California, the top 4 health agencies. What are consumers complaining about? Are the complaints about access to care? Are the complaints about denial of payment? And we are taking the data from the Department of Managed Healthcare, the Department of Insurance, Covered California, the Exchange, and Medi-Cal data, and we are putting it together and issuing a report. This is not a cute little 12-page pamphlet. This is a big Mamacita report, and it'll be coming out this fall. We are the first state to do this, and I think it's a really big deal. The industry knows we're doing this. But we are also doing ratios that show how plans are doing compared to their competition. So we have to do this every year, so we'll be doing it again next year and the year after that. So it's a big deal. It's also a statutory requirement, so this is not something I'm approaching casually. We also, that'll come out this fall, maybe the very first week of January. I hope as soon as I'm just wild to get that out there. We also are taking over the Medicare report card for California, and that will be, I'm saying spring of 2016. It won't be till the next year, next October, but it has data from the P4P program. I won't go into that because I'm on a very short string about how much I can talk. If you don't know what P4P is, then I'll talk to me later. We're also adding total cost of care data, which is for medical groups, and we will be displaying that information, not like it costs $65 for a doctor visit, but we're going to be giving based on IHA data on the P4P program and giving legends that are average cost of care, above average cost of care, and below average cost of care. And with all the researchers in this room, you know there's not a direct correlation between how much money is spent on healthcare and the impact that it has. And so we're going to put that on with our star quality ratings to have both cost and quality, and the intersection of those two things we call value. So I'm really excited about that. That's going to start spring 2016. And the last thing that I wanted to make sure you knew about is the Department of Managed Healthcare, which is one of our closest partners and allies and confederates, are putting together information on the timely access to care for health plans. And when we get all of that figured out to make sure that that is real and valid, and they are working so hard on that and in collaboration with us, that's going to be on our website as well. And that remains one of the things that consumers are most concerned about. I can't get an appointment. I can't get in to see a doctor. I can't do the kinds of things that I think I need to do, or my doctor has referred me to somebody and I can't get in. So that, I think, will be later than spring of 2016, but we're working fast and furious on that, and I wanted you to know that. The last thing I want to tell you, I think one of the reasons I accept these kind of engagements, I think they're very important, is I don't know which of you in the room already know something about this and can do some things to make sure we are better known. I think we are a really good agency that has an important mission, but I think we are nowhere near as well known as we should be for the function that we perform. And I'll tell you an example. Even people I think should know about us don't seem to. And people who are allies and have an interest in healthcare and quality and data. I came back from lunch a couple of months ago now. There's a huge rally going on outside of our office, and there were several hundred people there. And I went and listened for a while, and I talked to one of the women who was running the rally. And I asked her what they were complaining about, and they said they did not think that the health plan, who will remain nameless, had enough practitioners, providers signed up with them, so the consumers have to wait way too long. Yes, you can have an appointment, but it'll be a year from Thursday before you can get it. So she said, we're really concerned about it. So I listened to their message for a fairly long time, and the tagline, the end of that was, if you have those kind of problems, talk to your legislator and they will change the law. So I went and tapped her on the shoulder and I said, actually, that's a very good thing. We certainly support our legislators, but what you should really do is file a complaint with the Department of Managed Health Care. They track complaints, they look for trends and patterns. When they start to see stuff that's not going right, they start doing look-behinds and doing non-routine surveys and looking at that kind of performance to see if it really is a pattern. So I gave this woman my card, and I told her, you know, have your leadership get in touch with me, I'll explain. I mean, we don't take complaints because I just don't have the staff to do it. Our staff has been cut, and we have a different function. But you should, in addition to contacting the legislature, you should be sure that you file a complaint. Not maybe you yourself, but the people that complain to you. And the folks I was talking to were SEIU, the Service Employees International Union. So the next thing I knew, they had taken my business card, which I will be giving to many of you today, perhaps, and I think they put it up in the restroom at the Greyhound bus station because I got an awful lot of calls. Can you fix this? What's wrong with it? So finally, the union local president called me, and I explained it all to him. And they are actually allies, but they never knew anything about DMHC's complaint function. They never knew anything about OPA's quality data. And this is a tragedy. So the thing I'm asking all of you to do is if you're awake enough now to be paying attention to what I'm saying, please be sure that you give some prominence to the complaint function at the Department of Managed Health Care and to our quality data and the stuff that's coming, because it's way important. Thank you so much.
Thank you, Beth. And while the dean gets to the microphone, I just want to say that the Department of Managed Health Care also has a complaint function for the providers. So if the providers, like Marianne Champagne, have a problem, these two ladies could be a huge help to you.
Thanks very much. I'll just say that it's an honor to be able to host you guys. Thank you all for coming. I'll share some additional comments after lunch. We're on a short time horizon because Art Agustin has to get to a plane, so I'm not going to take more time. But there is one thanks. I want to underline all the thanks that Hattie said. I want to thank the state for their support for this initiative. But really important, none of us would be here if it weren't for the grateful patient Energizer Bunny to my left, and that's Hattie Hanley. And I think we all owe her a big, huge round of applause. So it's a real pleasure that this initiative stitches together so many parts of the UC system, our partners at the south of the Bay at Stanford, USC, universities that are here from Florida, from all over the place. And one person who needs no introduction to you is Arnie Milstein from Stanford, because he's been with you since the beginning. And so I'm going to ask him to come up and speak. I'm going to share a few thoughts after lunch when we have a little bit more time. Thank you all very much.
Well, in the spirit of healthy competition between different California universities, I'm going to finish in about the same amount of time as Dean Bertozzi. Every year before we get together at this meeting, I just go onto the Commonwealth Fund website, essentially see where we collectively have how we're doing in our state's rankings versus other states on a plausible way of ranking states on quality. And for those of you who don't check the Commonwealth Foundation website, we're still in the third quartile. We're not down there with Mississippi and Florida, but we're not that far above them. Now, the good news in California is that we do have some nationally distinguished islands where that are right at the top of the nation in terms of measures of quality and as courtesy of the IHI and Beth, and on total cost of care, the other key dimension of healthcare performance. But so far, our ability to scale things quickly has not been particularly impressive. We've got these islands, and the islands talk about how they do it, and then a year later, the gap remains still substantial. Now, scaling better ways of delivering healthcare that deliver more health with less money, is a little bit harder than convincing farmers to plant hybrid corn. Healthcare delivery methods are, it's a complex form of human behavior, and our ability to rapidly scale those kinds of changes is a little bit more challenging than planting different types of corn. I think generally the idea here is to get clear on the key leverage points. People who study complex adaptive change in complex adaptive systems say that typically what works best is identifying a few simple rules and then pushing and getting cooperation around those few simple rules. Sometimes discerning those few simple rules isn't easy, but that's one of the benefits of us getting together like this. We begin to kind of discern the critical features that differentiate our high performers from the rest of us. Fortunately, we have a lot of tailwind now to want to improve faster. We have transparency, as briefly referenced by Beth and led by both Medicare and the state, and some private initiatives like IHA. And professionally, we know that transparency, primarily works via not so much changing where consumers go, but more embarrassing providers into stepping up to their vision of what they want to be. We also, courtesy of Medicare, especially over the last few years, beginning mid-Bush and now extending right through Obama, have this idea of payment for value, varying how much we pay, based on value, sometimes through voluntary programs like ACOs, sometimes through involuntary programs, which is what MIPS, the new physician incentive program that will go into effect in 2019, will be. And then we have something that, I think, is probably the single largest motivator to ever come our way for those of us who are interested in improving value in healthcare, and that is market share incentives. And we sort of saw the first wave of this in the exchange plans. The big winners in the exchange plans were the plans with the lower premium but with no degradation in metal standard. And the way they did it, they got more selective about which providers are in their network. A lot of complaints from the providers who were not included in the networks. But the emerging research over the last 6 months suggests that on average the quality ratings are holding up in the narrow network plans. And since the private plans is where all the margin comes from for doctors and hospitals, that's why I describe this as the single most powerful motivating force to ever come our way. And I think you can think about what happened in the exchange plans as an hors d'oeuvre. And I think if the Cadillac tax, is able to politically hold in Washington, it's now you're going to see that same approach now seep into most commercial health insurance plans. And I think that more than anything else is going to get us all get the people who lead American healthcare and California healthcare really interested in doing more with less. Let me close by saying, so what about what are we doing today together besides complying with Hattie, which I've learned is it's a good idea to do. And and I think what this is about is professionalism. It's sort of we're collectively we're ranking nationally in the third quartile. We're a wealthy state with a lot of talent. We should be doing a lot better and moving up a lot higher. And at the end of the day, to use an overused term, this is on our watch, on our